This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. It is truly my pleasure to introduce two of our own speakers today, and my colleagues who work with them will wholeheartedly agree that we're very, very fortunate at Emory to have these two with us. I'm going to start off with introducing Dr. Annie Van Beuningen, who is an assistant professor and heart failure specialist at Emory and medical director of the heart transplant program. Dr. Van Beuningen is in her fifth year at Emory, and this year she was appointed the medical director for the transplant program. She earned her undergraduate at Brown University in neurosciences, followed by MD degree at Johns Hopkins, and where she also did her internal medicine and residency, internship and medicine residency there. She did her general cardiology fellowship training and cardiology training at Mass General in Boston, followed by heart failure, advanced heart failure fellowship there. Her main interests are expanding access to heart transplant patients and VAD therapy. She is part of ACC, AHA, Heart Failure Society of America, and numerous Emory committees specifically focused on heart failure and pregnancy and outcomes. She's founded and organized the Heart Transplant Retreat, revamped the way that we sort of organize a clinic for post-transplant patients and heart failure referral. She's received numerous teaching awards and scholar awards throughout her training. She's very interested in medical education and lectures to medical students and fellows, and has a special interest in cardiopulmonary exercise testing. And she is going to give a talk today, and then followed by Dr. Mahmoud Abdou, who earned his medical degree from Benghazi University School of Medicine. He completed his internal medicine and cardiology fellowship training here at Emory, followed by additional fellowship in heart failure and transplant at Indiana University School of Medicine. After completion, Dr. Abdou decided to return to Georgia, fortunately for us. But first, he went to Northeast Georgia Health System, where he played a key role in launching their LVAD program. And then about 6 years ago, joined us here at Emory. And he's currently serves as the medical director of the LVAD program. He has a special interest in cardiogenic shock, mechanical circulatory support, and group 2 pulmonary hypertension, and has been a co-investigator in several of the industry-sponsored trials that are currently ongoing in this area. He's very well known for his passion for teaching and service. He's received the Juha Koko Award and Golden Apple Award. And we're just very fortunate that both of these individuals have decided to give us our talk today to update us on heart failure transplantation and LVAD therapy. So I'll turn it over to Dr. Van Beuningen.
Thank you so much, Dr. Mehta. Truly, it's an honor to be here. Dr. Abdou and I are thrilled to speak today. Hopefully, many of you were able to join last week for Dr. Farano's lecture on really the pillars of heart failure therapy in 2025, guideline-directed medical therapy. And today's talk is really going to be an extension of that. We want to share with you what we're able to offer those patients whose disease has progressed despite optimal guideline-directed medical therapy. And then we also wanted to share with you some major updates and sort of key information about our own programs at Emory, both the transplant program and the LVAD program, because we've made a ton of changes and progress and innovations over the last couple of years that we're excited to share with you. So this is going to be really a talk in 3 parts. So again, the first is I'll provide some updates on management of stage D heart failure, going beyond guideline-directed medical therapy. I'll talk a little bit about when and for whom it's appropriate to refer patients to CS in our advanced heart failure clinics. And then again, Dr. Abdou and I will provide some key updates about our current transplant and LVAD programs here at Emory. So to start, again, as we all know, and we heard a great talk last week describing this, really the current management of heart failure with reduced ejection fraction is based on the foundational 4. And we all know that all patients should be managed with an evidence-based beta blocker, an angiotensin neprilysin inhibitor, an aldosterone antagonist, and an SGLT2 inhibitor, and titrate those for drugs to maximum tolerated dose. There's been, an incredible advancement in the knowledge about guideline-directed medical therapy out in the community. And for the most part, patients that we're seeing now who are being referred to us are often being referred on maximal tolerated doses of these 4 drugs. So this is really something that even within our advanced heart failure practice, we're encouraging general cardiologists and even in some cases internists to start and manage in their own clinics. Here at Emory, as well as other programs around the country, there is robust support from pharmacotherapy clinics. We have pharmacists who are able to titrate these drugs. And so it's a really, a multidisciplinary approach, starting in the internal medicine and general cardiology clinics to get patients onto these drugs. And really the role of advanced heart failure in the modern era is to think beyond guideline-directed medical therapy. So some of the things we consider for patients who are referred to us when they've been managed by a general cardiologist are things like vericiguat or additional novel guanate cyclase stimulators. We think about the use of drugs like ivabradine for patients who have persistent tachycardia despite maximally tolerated beta blocker therapy. And then there are new device-based therapies which are coming into more widespread use. Things like the barostim, which is modulating baroreceptor activity at the level of the carotid. And then we think about cardiac contractility modulation, which is a device-based therapy, a device that's similar in appearance and size to a implanted ICD that provides contractility modulation in an implantable invasive way. And so again, these are the types of therapies and things we consider when patients are referred to us already on medical therapy. And that's the role that we're playing in, again, the modern era of GDMT. And we really want to emphasize that the advanced heart failure team is an extension of care for our patients, not a replacement for the primary cardiologist. We have a lot of different models that we employ to see patients. We have a number of practices with whom we have very effective shared care models. We do telemed visits with heart failure for patients who are further out in the community. And again, our role is really to consider novel medical and device-based therapies. We have also a number of open enrolling clinical trials that we have access to, and we can provide information for patients for. And then another big thing that we're able to offer, which I'll get into a little bit more, is risk stratification for those patients who we think are, in the advanced stages of their heart failure. And then finally, we can also start to think about when and if it would be appropriate to move to more, advanced invasive treatment options for heart failure, including inotrope therapy, transplant, and LVAD. So which are the heart failure patients who we should think about referring to advanced heart failure physicians? All patients with reduced ejection fraction who meet any of these criteria should be seen in our clinic. So anyone who's had 2 or more heart failure hospitalizations in the last year, patients who are having symptoms despite optimal medical therapy. And this includes things like persistent but stable dyspnea. Those are symptoms that, someone who's saying, I have good days and bad days, I do okay as long as I take it easy. Those are patients who are still having symptoms. They might be stable, but if they're on optimal medical therapy, those are patients who should be seen by our advanced heart failure group. Any patient with intolerance to guideline-directed medical therapy, whether it be side effects that limit the use of all 4 groups of drugs, whether it be hypotension, such that we're having to pull back on someone's beta blocker or their Entresto dose, and then also worsening end organ function. So if we're limited in our ability to titrate, Entresto or spironolactone or the SGLT2 inhibitors because of worsening renal function, patients who are developing ascites or evidence of congestive hepatopathy, these are all patients that should be referred to our clinic. And then thinking beyond just heart failure with reduced ejection fraction, any patient with refractory cardiac symptoms with no further standard treatment options, even with normal LV function, should be referred to our clinic for further consideration of advanced therapies. So this includes things like recurrent VT, patients who are on their 3rd, 4th, 5th ablation despite antiarrhythmic therapy, patients who have unrevascularizable coronary disease with persistent angina, advanced congenital heart disease, patients with evidence of end-stage sarcoid, amyloid, and hypertrophic cardiomyopathy, patients with valvular disease that are deemed not suitable for intervention or not amenable to intervention based on anatomy or other reasons, and then patients with primary RV failure. These are all patients who we can consider for advanced therapies. And so it's important, again, to remember that even with normal LV function, there are a lot of good reasons to have your patients seen in our clinic, because we can start to think about whether they might be candidates to move, again, to an advanced therapy model. I really want to emphasize that early referrals save lives, and it's never inappropriate to have a patient seen by our clinic, even if they're thought to be doing well. So I just want to share with you a clinical case that I have seen here at Emory. So this was a 65-year-old male with an idiopathic dilated cardiomyopathy, had been diagnosed for several years. His ejection fraction was stable in the 30% or so range, was followed in general cardiology clinic, and was referred to me just to get plugged in with advanced therapy that was not felt to need that at the moment. This patient had fairly minimal symptoms, reported golfing regularly, was tolerating some medical therapy on metoprolol succinate, Entresto, spironolactone, had never been hospitalized for heart failure, and had normal end organ function. So I saw this patient in clinic, and despite, on paper seeming to be stable and doing fairly well, upon further questioning, yes, he did golf regularly, but again, had some of those red flag descriptors. If I take it easy, I can walk. If I'm having a good day, I can get through 18 holes. These types of symptom descriptors are really red flags to us that this is a patient who might need more investigation as to the status of their heart failure, going beyond just an echo. And then it also turned out that even though on paper he seemed to be tolerating a reasonable amount of medical therapy, his metoprolol and Entresto had to have been decreased in their dosage because of relative hypotension. And again, these are all sort of warning flags that someone might be progressing from stage C into stage D disease, and is definitely appropriate to be seen by our group. And one of the things we're able to do is do risk assessment or risk stratification for these patients. And the main way that we do that is through cardiopulmonary exercise testing. So I'm going to pause for a minute and just highlight the incredible prognostic value of cardiac pulmonary exercise testing for patients with heart failure. So exercise variables are truly prophetic in this patient population, and this is supported by really decades of data showing us that CPET variables are the most powerful predictor among patients with heart failure with reduced ejection fraction as to who is going to go on to need a transplant or VAD within 1 year. And I really want to highlight not necessarily the details of this fairly busy graph, but this third CPET variable, the third from the top here, the presence or absence of this metric alone, and again, less important to know exactly what it is, but more so that the finding of oscillatory ventilation on an exercise test among patients with heart failure confers a 35% 1-year mortality risk versus its absence, which confers only a 4% 1-year mortality risk. And this is true for a number of CPET variables independent of one another, and important to highlight that these studies were all done in patients with stage C or D heart failure who are assessed to be NYHA class 3 primarily by cardiologists. So this is not comparing, again, normal patients to patients with heart failure, where this would obviously bear out. But again, this is among patients with heart failure on medical therapy. These CPET variables are highly, highly prognostic and confer significant risk of mortality when present. And also important to know that CPET variables have outperformed basically every other assessment of a patient's clinical condition in head-to-head trials, including ejection fraction, including physician adjudication of NYHA class, and importantly, these actually outperform resting hemodynamics. So truly a critical piece of information that we're able to get for our patients with advanced or thought to be advanced heart failure. So back to the patient I was describing before, I saw him in heart failure clinic, again, was a little concerned based on some of the clinical findings, ordered a CPET, which was exceedingly poor. His peak VO2 was only 28% of predicted, which is very, very abnormal. And he additionally had multiple other extremely high-risk findings. And really based on that information alone and the duration of his cardiomyopathy, we started an outpatient transplant evaluation. Now, unfortunately, he had an out-of-hospital cardiac arrest, ended up on ECMO. But because most of his evaluation had been done as an outpatient, we were actually able to transplant this patient within a week of admission on ECMO. Now, obviously, this is an unfortunate outcome, and seeing me in heart failure clinic did nothing to prevent his out-of-hospital arrest. However, because we had gotten the ball rolling on the outpatient side, we were able to move quickly and able to save this man's life. So again, referring early and often to heart failure allows us to start thinking about advanced therapies before patients become too sick. And importantly, one of the major things that we do in our clinics is identify and work on modifiable barriers to advanced therapies while we have time. It is so devastating to us when we only meet patients in the ICU who've had longstanding heart failure who didn't realize that certain behaviors or certain issues were going to preclude them from transplant, and only learn this while it's too late. It's so important that we're able to have these conversations with patients while they're well, while they're with their families and being seen in clinic. And again, we really want to focus on our clinics employing a shared care model. So the primary cardiologist continues as the longitudinal provider, manages standard medical therapy and all of the patient's additional cardiac comorbidities, and provides that continuity of care and that really, sort of quarterback of the team, where the advanced heart failure team thinks about things like clinical trial enrollment, emerging medical and device-based therapies, and then again, begin to evaluate the patient for LVAD or transplant when appropriate. So I'm going to switch gears a little bit and spend some time talking about our own heart transplant program. We're so proud of the changes that we've made over the last couple of years, the recruitment of new staff and faculty, and looking to the future, really innovating and driving transplant care forward. So we've had some changes in leadership recently. As Dr. Mehta mentioned, I'm the new medical director of the transplant program, and we were so thrilled to be able to recruit Dr. Victor Pretorius as our new surgical director, who started at the beginning of the month. He comes to us from the University of California at San Diego and brings decades of experience growing a transplant program there. But we're supported by a very large multidisciplinary team, which really enable us to provide wraparound care and comprehensive care for our transplant patients. We have now 15 dedicated heart failure cardiologists. We have 5 heart failure cardiothoracic surgeons who perform our transplant and LVAD surgeries. We've grown tremendously in our coordinator group. We have dedicated pre and post-transplant nurse coordinators to really walk our patients through every step of the process, beginning from evaluation to 5-10 years out from transplant. In the last year, we recruited and onboarded 3 dedicated transplant APPs who see our patients both in the hospital after their transplant surgeries and in the clinic. We have dedicated financial coordinators who help our patients walk through and navigate some of the challenges with insurance as it relates to transplant. This is something that is critically important to know as well, that within the transplant center, we have support to help patients with things that might otherwise be difficult, like changing insurances to get onto a plan with transplant benefits at Emory, and things of that nature. So we're really able, again, to offer comprehensive care to our patients. We have dedicated social workers, 3 transplant social workers who see our patients, again, before and after transplant. We have dedicated pharmacists as well. And this large team is growing because we're supporting a busy and growing program. This is our heart transplant volume year over year going back to 2018, and you can see that we've had really sustained growth, and we expect we're on pace to meet or exceed our volumes last year in 2025, which we're thrilled about. And compared to programs nationwide, we're a very high volume center. So this is a graph showing the number of transplant centers plotted against transplant volume for the year of April 24 to March 25. GAEM is our transplant program code. So you can see that we're well into the top quartile of transplant centers by volume nationwide, which we're also very proud of. And not only are we proud of our volumes, but we're really proud of the steps we've taken to advance and innovate in transplant care. And we focused on a number of specific areas. So the first are broadening our indications, or what we think are typical indications for transplant. We've made a concerted effort to expand our recipient selection criteria. We are looking at ways to increase the donor pool so that we're able to save more lives. We're really focused also on pushing boundaries in organ preservation, again, to allow us to access donors that we historically might not have had access to for our patients. And then really making sure that we're staying on the cutting edge of new technologies in post-transplant surveillance and management. So I'm going to spend some time going through each of these. In terms of indication for transplant, as I mentioned, we really are thinking now beyond just stage D heart failure with reduced ejection fraction to other end-stage cardiac disease. So again, refractory VT, intractable angina, end-stage infiltrative cardiomyopathies, valvular disease, again, ARVC and congenital patients as well are all patients we've had success in transplanting in the recent years. In terms of our recipient selection criteria, we are really focused on offering a chance at transplant to as many patients as possible. And what we've done to do that is to extend our age criteria. So we're now considering transplant in carefully selected patients over the age of 70. We are also considering transplant in specific patients who didn't meet our sort of historical criteria for BMI. Things like A1C, we no longer have strict cutoffs for A1C, but are rather considering each patient as an individual, looking for those macro or microvascular complications of diabetes that might pose an issue after transplant, but not having black and white cutoffs. So that, again, we're considering each patient as an individual. We similarly have made changes to our substance use policies such that alcohol and THC use are evaluated on a case-by-case basis, but are no longer considered absolute contraindications to transplant. And last, we are now able to offer dual organ transplant to our patients. So patients who with end-stage kidney disease, patients with cirrhosis from congestive hepatopathy, patients with advanced pulmonary disease are eligible for dual organ transplant here, certainly in specific circumstances, but it's something we want to be able to consider and certainly something we can offer to the right patients. We want to increase the donor pool. There's a severe imbalance between the number of donors available every year and the number of patients on the transplant list. And so a big focus within the transplant community at large and also here at Emory is thinking about how can we potentially expand the number of donors that we're able to use. And one of the ways we're able to do that is by using donors who have had cardiac death rather than traditional brain death, something called DCD donation. We are now able to safely use hearts from donors who have hepatitis C. With advances in the treatment for Hep C, we're now able to essentially use those Hep C positive donors. We treat our recipients preemptively for hepatitis C, and that's a safe way now that's been made big impact on the number of donors that we're able to use. We're also now considering older donors. Donors over the age of 50 were historically not thought to be suitable for transplant, but it turns out that for carefully selected recipients, older donors are safe and have similar outcomes to younger donors after transplant. So really thinking about, again, ways how can we use organs that we might not historically have thought were usable to allow access to transplant for more of our patients. There's been incredible innovation in the last 3 to 5 years in terms of organ preservation. So thinking about ways to get the organ from donor at hospital X to the recipient at hospital Y. And are we able to think creatively about how to do that such that we can have access to more donors? And one of the things I like to tell patients is, just about the only thing that's true in medical shows and movies is that human organs are brought in coolers from donor to recipient. That's no longer true. And hopefully the video is playing, but this is an example of a heart that is being perfused on what's called an organ care system. This one is made by a company called Transmedics. But now what we're able to do is recover hearts from the donor, essentially attach them, as you can see in here. These are surgically anastomosed or surgically grafted to the organ care system. The heart is then reanimated on the device, is perfused with donor blood, and then transported from the donor to the recipient at Emory or any other receiving institution. And this does a couple of things. It allows us to potentially extend the geographic radius with which we're willing to go and procure organs because the organ is perfused during transit rather than sitting in cold static storage, which means essentially on ice. We're also able to look at the heart as it's beating, as you can see here, and assess whether it really is going to be a heart that's suitable for transplantation. And this allows us to push the boundaries in terms of the donors that we're considering, if we have that reassurance that we can assess the organ while it's beating on one of these OCS devices. We're able to do things like check serial lactates in these organs. We can consider things like coronary angiography while the organ is on an OCS device. And it really allows us, again, to evaluate these organs in a way that we weren't able to before. And because the organ is perfused while it's on the device, this also can dramatically cut down the amount of ischemic time that these organs are seeing in between donor and recipient, which again allows us to consider organs that we might not have used previously. And the last thing in terms of post-transplant management is really staying on the cutting edge of new technologies for surveillance and management of our grafts once our patients have been successfully transplanted. Historically, the endomyocardial biopsy was really the foundation of post-transplant management and surveillance. This, as you all know, is an invasive procedure that involves venous access either through the IJ or the femoral vein. We then pass a catheter containing a bioptome, a small bioptome into the right ventricle, and take 3 to 4 tissue samples per biopsy that are then analyzed in a pathology lab and surveilled for cellular and antibody-mediated rejection. Although overall the biopsy is a relatively safe procedure, you can see here almost 96% of patients in large studies have no complications, and it's venous access. So, compared to some other types of procedures, relatively safe. However, we do still see that in about 4% of patients, there can be a number of complications. And importantly, because of the frequency with which we need to surveil these patients and these grafts with biopsies, a 4% per procedure complication rate might be trivial, but for patients who are having 8, 9, 10 biopsies over the course of their post-transplant care, this can really add up. There's also, some logistical considerations with need for cath lab time for biopsies, and certainly patient discomfort as well as is a significant factor. Again, mainly based on the number of biopsies they have to have, not because each individual biopsy is such a burden. What's really revolutionized care for our patients, however, in the last 5 to 7 years, is the incorporation and use of donor-derived cell-free DNA into the management of our transplant patients. So the concept of this is fairly simple. Although the majority of our DNA is contained within the nuclei of our cells, during the process of natural cell turnover or cell lysis, some of that DNA is released into the bloodstream and becomes what's known as cell-free DNA. And this is true for both the recipient and for the donor graft. This was actually first brought to market for prenatal non-invasive diagnostics. There is fetal-derived cell-free DNA in the maternal blood circulation, and that allowed the early detection of potential aneuploidies and allow for sex determination via non-invasive methods. And this was then brought over to the transplant world for monitoring of our donor grafts. And so how this works in practice is that we take a recipient blood sample, which contains a mix of donor and recipient cell-free DNA. The companies that we use for this assay then perform a SNP analysis on both the donor and recipient cell-free DNA. And when the graft is healthy and there's no active inflammation in the heart, in the donor heart, there should be relatively minimal or almost no donor-derived cell-free DNA in the recipient's blood. However, in states of active cell injury, when there's myocyte damage leading to lysis and necrosis, there's going to be donor-derived cell-free DNA that is released into the recipient bloodstream. And we can assess and actually quantify the percent of donor-derived cell-free DNA. And this has really revolutionized how we're taking care of our patients post-transplant. We are minimizing the number of surveillance biopsies that we're performing and instead surveilling patients with a simple blood test, which goes a long way in terms of cost, logistics, and patient satisfaction in our post-transplant management. In addition to donor-derived cell-free DNA, there are now a number of ways that we can use molecular diagnostics for post-transplant care. We look at things like donor-specific antibodies to assess for the presence of antibody-mediated rejection rather than using biopsies. We use gene expression profiling through mRNA assays to surveil for cellular rejection. We are now able to perform molecular diagnostics on our biopsy samples when there is, clinical equipoise about the histologic pathology. We're able to, again, assess mRNA profiles in biopsy samples as well, which again has really revolutionized our ability to be precise and specific with our therapeutics and really understand at the molecular level what is going on with these grafts post-transplant. So again, just to summarize, these are the areas that our program is really focused on heading into 2026. So broadening the indications for heart transplantation, making sure that we're thinking about every recipient as an individual and finding ways to help patients get to transplant. And then using novel technologies to increase our donor pool through ex vivo organ perfusion. And using cell-free DNA, gene expression profiling, and additional molecular diagnostics to really ensure the best outcomes for our patients. And I'll just end with what our sort of program philosophy and mission statement is as a transplant program. And this is to provide access to life-saving transplants for all patients in need and incorporating novel technologies to ensure excellent outcomes for our recipients. Well, thank you very much. And I'm going to stop sharing and pass it over to Dr. Abdou now, who's going to provide you with updates on our LVAD program.
Thanks, Annie, and thanks, Dr. Mehta, for inviting us. It's always a delight and a pleasure to talk to you and be on this platform to provide an update on the latest and greatest of our advanced heart failure therapy program, as Dr. Van Beuningen mentioned. I am directing the LVAD program on the medical side, and Dr. Mani Danishmand, who is known to us, is directing the program from the surgical side. And what I'm going to do today is going to take you through a journey through the evolution of durable LVADs. Kind of touch upon some historical data, and then where are we now and where we envision ourselves going in the future. As most of you on the call here remember, some of you are junior may not remember. These are how we went from durable mechanical circulatory support back in the days to where we are today. This is the HeartMate XVE. This is the first generation pulsatile pump. It was the first pump that was approved as a durable mechanical circulatory support. Was supported through the rematch trial compared to medical therapy. Obviously, these pumps are very bulky. They're mechanical, they are prone to break, and we don't use them anymore. After that came the HeartMate 2, which was the powerhouse of durable mechanical circulatory support back in 2010, all the way throughout that decade. It was the axial flow device. It was a continuous flow device as well. Was the first continuous flow device. Was tested in the HeartMate 2 against the HeartMate XVE. This has no longer been produced because there's more future generation of mechanical support that have been manufactured. Then you have the Heartware HVAD, which came to approval in 2014 and has been also able to support a lot of patients during that era. And in June of 2021, the manufacturing company withdrew it from the market due to patient safety issues. However, it was really well tested against the HeartMate 2 in the endurance trial, and no longer manufactured as well. Now comes the HeartMate 3, which is the latest generation of durable LVADs. It's the fully magnetically levitated device that was tested in the landmark Momentum 3 trial. and it's the only FDA-approved device right now on the market to support patients with durable LVADs. This is I showed you data and clinical trials. What about real life data and experience? This is data from the National STS Intermax database published in the Annals of Thoracic Surgery. Our own Dr. David Vega was the senior author on this publication. And as you can see, there are the total volumes of LVAD implanted in the United States over a decade from 2013 to 2021, or 2022, sorry. And you can see the total number of LVAD implants seem to be dropping compared to 2015, but it's actually 2019 where it marks the dominance of the HeartMate 3 LVAD in the new era of durable LVAD support. This is the landscape of advanced heart failure therapies as we know it today. This is the national trends of heart transplant compared to LVAD. As you can see, after 2018, actually the total volumes of heart transplant throughout the country has risen nicely, and it continues to rise, versus we see a small decline in LVAD use, thought to be related to the new implications or implementation of the newer heart allocation organ heart allocation system throughout the United States, which led to more volume in heart transplant. A lot of people look at this slide and really are happy about it, but I want you to pay attention, or draw your attention to the top line here, which is the total number of advanced therapy patients treated from 2018 to 2022, and you can see that despite the increased number or steady increased number of heart failure patients, the number of patients who are treated with advanced therapy seems to be flat. And to me, that may be a red flag and maybe a slight disappointment there, despite what we heard last week from Dr. Van Roo about the trends of heart failure patients in general. I'm going to take a dive in next few slides and show you a comparison between the current generation LVAD, the HeartMate 3, and compare it to the old generation LVAD and real life data. Again, this is data from the STS Intermax national database showing the 5-year survival of patients supported with older generation HeartMate or HeartMate 2 or HVAD. These were remarkable devices, and we were really advancing the field of cardiology with the use of these devices. However, as you can see, in 5 years, more than half of these patients are dead. What about nowadays? Nowadays, we have a very impressive improvement in survival from around 40% at 5 years to 65% or so with patients supported with the HeartMate 3. Not only do these patients survive and live longer, however, they live better. This is a graph of the same era showing you that the time for the time for the first major complication, being a stroke or device malfunction or pump thrombosis, actually has increased significantly. Compare this almost 60% of the patients had some sort of disabling stroke or need for pump thrombosis, or need for pump exchange. Compare that to only 72%, 70% people have not have any complications at 5 years. And this benefit is also seen here very early as well, where you can see that these patients have less complications. Even in GI bleeding, these devices, or HeartMate 3 is a more hematocompatible device that really does not lead to a lot of bleeding complications, and you can see this highlighted here. Same thing. Instead of this is another slide for the pump thrombosis. Compared the HeartMate 3 here in the green slide, compared them to the HeartMate 2 HVAD in the past. Now, the one area that we did not make a lot of improvement is in device infection and driveline infection, and you can see that there is not a difference at all between the newer generation LVADs and the old generation LVADs in terms of device infection or driveline infection. Driveline infection. And this is an area that needs to be further discovered and improved upon. And I consider this the Achilles heel of LVAD therapy as it happens right now. What about now? Where are we right now, and where are we at here at Emory? This is a slide that shows the trend of volumes of LVADs compared to transplant. From 2015 throughout 2018 or so, we were known to implant around 30 or 40 patients and transplant 30 or 40 patients. But really, the LVAD program took off steeply after 2019. In 2021 and 2022, in two consecutive years, we were the #1 implanting center in the United States. And we maintained that large volume of LVAD implant by volume since then. And we've been consistently in the top 3 to top 5 programs in the country, giving patients hope and another shot at life when there are barriers to transplant. We truly stand on shoulders of giants here at Emory. Highlighted here are the pioneers and the foundation of this program, starting with Dr. David Vega, who implanted Georgia's first durable LVAD in 1999 to serve as a bridge to heart transplant, which initiated Emory's ongoing national position at the forefront of the use of mechanical circulatory assist devices. The medical leadership of Dr. Andy Smith set the stage for ongoing success, and the most recent and wise, steadfast leadership of Dr. Raja Laskar that navigated the institutional growth of the LVAD program, and we will be forever grateful for all their dedication to our patients, trainees, and to our institutions. Our unique patient population in the state of Georgia certainly has its challenges when it comes to candidates to advanced therapies. This is work done by Elana Morris during her tenure here at Emory. She sought to identify these challenges and the risk factors associated with them. And as you can see, the reasons for ineligibility for advanced therapies was not equally distributed amongst different genders and race, with Black patients and females being the most disadvantaged to being considered for these therapies based on medical reasons, but more so strikingly or not so strikingly, psychosocial reasons or also barriers more prevalent in the Black patient population compared to white. Obviously, this was a problem to us, and what did we do? Efforts led by another 2 giants that we had here at Emory, and we still have these. We are always forever grateful to all the work they have done to this program in multiple levels. Dr. Divya Gupta and Elana Morris implemented rigorous bias training that took place in 2019, involving the CICU staff and the multidisciplinary team members. This led to ease in social support requirements for patients undergoing LVAD evaluation in September of 2021. And as you can see, the graph demonstrates a significant rise in LVAD implants at Emory, with a notable shift in the racial composition of recipients, showing an increased proportion of Black patients receiving the device. This shift aligns with the implementation of institutional bias training programs and policy changes aimed at reducing barriers to care. And as a recent trend of expanding LVAD therapies to sicker patient population, a specific interest of mine was to study the association of renal function and patients receiving HeartMate 3 LVADs. Interestingly, when we grouped 3 patients into 3 groups, those who had normal renal function, those who had eGFR between 30 and 60, and those who had severe renal dysfunction, we did not see a significant difference in 1-year mortality, hospital readmissions, or dialysis requirements. Yet a more interesting finding is that patients who had proteinuria at time of implant tend to have more problems and need of dialysis and even mortality after HeartMate 3. This work has been spearheaded by Matt Brown during his fellowship, and I'm proud now to call him my partner. He will be one of our rising stars in our program, our division, and the department. 2 senior residents who were involved in this project since they came to Emory during their internship, Martin Osario and Daniel Matthews, both who will be chief internal medicine residents next year. Proud of their work and their achievements. I'm really excited for them to join the cardiology group and the cardiology community joined by a few junior residents, most recently Sally and Anna, who have been instrumental in getting this project reach the finish line, hopefully to publish this manuscript very, very soon. I like to show this picture. This is courtesy of Dr. Ugo Agalam. He's my partner in my previous job before joining Emory. This was how LVADs looked like, and this is sometimes the picture that's ingrained in a lot of people's mind. This was during his training as an intern not too long ago. This is a patient supported by PVADs awaiting transplant. When we had this was considered the norm, and it was a success for durable mechanical support. But this is where we are right now. And I'm going to show you a few pictures that I took written permissions from these patients to show their pictures and talk about their stories. I want to share the story of Gabby, who came to us as a referral only a few days after giving birth to her first child, 24 years old. She was not a transplant candidate because of prohibitive high antibodies and multiple hemorrhagic strokes. She came to us well supported on an Impella 5.5 and dense cardiogenic shock, underwent HeartMate 3 LVAD. And she was discharged from the hospital to rejoin her family and baby after 2 months. I saw her in clinic a few times right after her discharge, but last week I didn't really recognize her. I was rushing from the tower to the CICU, and her husband called my name, and literally both of them ran to me and gave me the biggest hug and kept on asking me to thank Dr. Muad Bishawi. He's one of our surgeons, and the whole team, and she's been doing excellent. Another recent happy story was Andrew. This is an 18-year-old young gentleman. He was happy with his $800 a month job at the Firehouse Subs, got sick, and was placed on VA ECMO at Children's Hospital. We were not able to transplant him due to pulmonary hypertension and high antibodies that were prohibitive as well. Mani Danishmand, who was pictured here in the picture, implanted a biventricular HeartMate 3 LVAD, meaning a HeartMate 3 LVAD on the right side and in the left side in a total artificial heart configuration. After 4 months in the hospital, he was discharged, walking on his feet with his family. And you can see a glimpse of Mani here cheering him through as Andrew was ringing the bell on 6E. Another young life saved. I saw him in the clinic last week, and he was doing phenomenal and still thinking of going back to work at Firehouse Subs. Where is the future? The future is not far from here, but I can tell you that with improvement in heart transplantation, as you heard from Dr. Van Beuningen, highlighting the advancements we have and the latest and greatest in heart transplantation that we are part of here at Emory, the future for durable LVAD is as bright and promising. Emory is and will remain on the front line of the cutting-edge clinical research in this field. Abbott is a pioneer in this field. Thoratec was the name of the company that Abbott bought a few years ago. Is the home for HeartMate 3 or all the HeartMate devices. They are working on improving their already magnificent HeartMate 3 that changed the world of LVADs as we know it. New peripherals with lighter batteries, improved connectivity, and home transmission of LVAD parameters. There's a rumor that there may be a HeartThread Mini that will be landscape changing. Emory is part of the Innovate trial, comparing the new magnetically levitated device called the BrioVAD. We are proud to be the first to implant this device in the United States, and we are the #1 enroller in the trial. Currently, we have 4 patients supported on BrioVAD. Bivacor is a company that is coming out with a clinical trial to study the newest biventricular total artificial heart. We are working on getting into this trial again as it launches. And lastly, a new player in the game is the CoreWave VAD, which will bring back pulsatility to LVAD world to mitigate the problems of continuous flow LVAD utilizing an innovative biological membrane that simulates a fishtail to deliver pulsatility. There's a lot of innovation in this field. There's a lot, so stay tuned for it. A lot to do with the integration of AI to enhance the functionality of these devices. And when I asked about the future of LVAD, who knows? Will Tony Stark's be a reality? I don't know. I often find myself asking, no wonder why Iron Man was my favorite Marvel superhero. I think this is just a coincidence, but I think just Iron Man is just so cool. With that, I really thank you very much for listening and tuning in for today.
Fantastic. Thank you so much, both Dr. Van Beuningen and Dr. Abdou, for wonderful presentations. We learned a lot. There are quite a bit of questions, so let's start there. Dr. Walker, do you want to unmute your mic and speak, or I can read
Yeah.
Okay, great.
Sure. I just want to thank you both so much. This is incredibly helpful. And having been at Grady for the past few years, where we mainly just have general cardiology, it's really helpful to review when to refer and stuff. My question is basically around, I think general cardiologists are basically kind of the gatekeepers of referral. And even my last week on service, there's lots of questions about, someone with uncontrolled lupus who is referred for, kidney, heart, or someone with end-stage renal disease on dialysis. Are they even a candidate? Someone with an LV thrombus, are they a candidate for an LVAD? And so I'm just curious if you have any advice on how people should approach patients that are typically not referred because general cardiology thinks they're not a candidate for advanced therapies, but heart failure might.
Yeah, thanks, Shannon. It's a super, super important question. I would encourage you and everyone else on the call to refer everyone, and not so that we can, again, like I said, sort of take over as our cardiologist, but because we are the really only group that should be determining whether someone's a candidate for an LVAD or transplant. And that's because, again, we are able to offer, we have sort of wraparound support that might not be available in the community, like financial coordinators, getting to the second question in the chat. But also, again, because as we grow as a program, we're constantly innovating and changing with new, surgical techniques. And, LV thrombus, just for example, is not a contraindication to LVAD or transplant. I love your question about lupus needing a heart kidney. That's a great question. I don't know what the answer is, and that's why we should be seeing these patients in our clinic. And if they're not, totally fine. That's not like an inappropriate referral. That's a completely appropriate referral for us to determine their candidacy. Again, I think the social support question comes up a lot, and I would encourage everyone to let us have our transplant social work talk to these patients rather than making a predetermination about what is sufficient or insufficient support. So I would just recommend that if there is someone who, again, is getting hospitalized repeatedly for heart failure, has any of those warning signs, just send them over to us, let us see them. Again, if they're not a candidate or it's too soon or whatever, that's not inappropriate. We are happy and want to see those patients because, in fact, typically the opposite happens. Patients, for a number of totally reasonable based on a number of reasonable decisions, but ultimately end up being referred way too late when they're in the unit on ECMO or whatever, and we're not able to offer them advanced therapies, or we're not able to address those modifiable barriers that we might have been able to address had they been sent in our clinic. So I would encourage you to send all of those patients. And again, if they're not a candidate, totally fine. It's not inappropriate. We're happy to see them.
Thanks.
Okay, our second question is from Dr. Oguni.
Yeah, thank you. Thank you for your presentation. I know you mentioned that we should refer all patients, but I'll push back on that a little bit. Most of our colleagues have been very helpful. And in fact, I think that if you say refer all patients who are uninsured or underinsured, there's a pushback, they can't even get to clinic. Or I had a situation where a patient could have even been transferred when I was on service. So I think that it would be helpful to have clear policies because we still get the push. But the patients that we've successfully transferred either or referred through clinic have insurance. So it will be helpful for us to have clear policies because to say refer all patients, they're gatekeepers, So I think that if you could share the policies that you have that will ensure that all patients, not just some patients, get into your clinic or get transferred, that would be helpful for us at Grady.
Yeah, thank you so much. This is something that we've really struggled with, and we don't have the perfect answer for. So just for some background, Medicaid in the state of Georgia does not pay for heart transplantation for adults, but does cover LVAD. And then obviously uninsured patients present a unique set of challenges. I will say as a program, because of our commitment to providing access to care for all patients, the institution is supportive of us transplanting patients who have Medicaid if they are considered not dischargeable from the hospital without a transplant or LVAD. I mean, Medicaid covers LVADs, that's not a barrier. So Medicaid patients are eligible for transplant. So certainly patients at Grady or elsewhere with just singular Medicaid coverage are eligible for transplant and should be referred. Patients who are uninsured, again, pose a unique challenge. We have had situations where, a patient's come over who's uninsured, is clearly not dischargeable, is in the ICU on mechanical support, and our financial coordinators have been able to get that patient onto either emergency Medicaid or onto a marketplace plan in their ICU admission, and we're then able to offer advanced therapies to them. In the outpatient setting, lack of insurance is a challenge, but again, I would encourage you to at least reach out about those patients. Again, we have 2 dedicated financial coordinators who are able to assist patients who are kind of in our group's purview, if you will, with navigating the exchange plan process, Medicaid enrollment, Medicare enrollment. So if there are barriers to patients, outpatients coming over for clinic based on transportation or whatever, like it's probably worth at least an email to see if we can start to help those patients even remotely before we see them to get them some sort of coverage. So it is definitely a challenge. It's something that we are like we struggle with and think about on a daily basis. How can we ensure equitable care? But again, I would encourage you to at least, if not reach out about all of these patients, because there might be ways that we can help that because of resources we have in our transplant center that are not available in the community. So I know that's not a super clear set of guidelines, but please, you can reach out to me directly if there's ever a patient who you're struggling to get over, and we can definitely try and help.
Great, thank you. And Orle had put in a plug for the new multi-center trial at Grady, Prevent HF, combining Baxdrostat plus DAPA. Just in the interest of time, I'm going to keep moving here. Dr. Sperling has a comment and a question regarding cardiac rehab, given the important role of CPAT that Annie, you highlighted. What is the current state of cardiac rehab referrals at Emory, specifically for HFrEF patients, post-LVAD and post-transplant patients? And do we have that data?
Yeah, I can answer that question. Thanks, Dr. Sperling, for the question. I personally believe totally in cardiac rehab for these patients, especially after their transplant and LVAD. And currently, what we have been doing is, cardiac surgery is, and as you know, of course, cardiac surgery is an indication for cardiac rehab, and we've been utilizing that for giving that approved through insurance and referral to cardiac rehab. I can tell you anecdotally, those patients who were very physically deconditioned, either throughout their surgery or right after their surgery, are the ones who benefited the most from cardiac rehab. I have few patients who I knew that underwent cardiac rehab, and they've been doing so much better after finishing their physical rehab. They go into cardiac rehab, and it's been great. So I'm hopeful that we can continue sending more patients to cardiac rehab. I believe cardiac rehab is an essential tool for all cardiologists for all indications, if you want to ask me.
Great, thank you. And Emory was a site for HF Action Trial. Dr. Sperling has put that in the chat. Thank you. Carolina has a question. How do we see a collaboration with general cardiology team instead of transition of patient care from general cardiology to heart failure? Could you comment on that?
Yeah, absolutely. Right now, there, as Annie mentioned, I mean, we believe in this shared care model, where, if you have a heart failure patient or patient with heart failure who you feel that either exhibiting one of these advanced heart failure symptoms or difficult to manage or etc. I mean, referring to the heart failure program or the heart failure clinic does not necessarily mean taking over their care. This is a very true shared care model. We've been successful in doing this on multiple sites. If anybody from the Emory Johns Creek Clinic will tell you how we're doing it, then doing it in a very nicely way where we see the patients and they can keep continuing seeing their general cardiologist. That way, they get plugged in and we can kind of really identify these early red flags that can be impactful in helping these patients risk stratify them a little bit more faster and easier and earlier and provide the appropriate care for them.
Great, thank you. You can just see by the number of questions and interesting discussion, I feel like I'm going to invite you guys every year to give an update because this was wonderful presentation. And thank you so much, especially just, getting us up to speed on what all is happening at Emory. If there are no other questions, I will close just in the interest of time. It's getting close to 8:35. So thank you again, and I will see everyone next week. Don't forget to get your CME.
Thank you.
Thank you so much.
The preceding program is copyrighted by Emory University.